Hello, everyone, and welcome to the March meeting of the Global Health Youth Organization. My name is Noraldine, and I'm a co-founder of the organization. We are very excited to see everyone who joined us today. I want to thank everyone for joining the meeting and working around any scheduling or time zone issues that you might have had. And as for the format of today's meeting, we will begin with a quick introduction of our speaker, followed by her presentation, and then a question and answer session. After the Q&A section, we will post a shadowing certificate link in the chat. We ask that all members stay muted throughout the presentation so that we can limit distractions and interruptions. Please feel free to add any questions or comments that may arise in the Zoom chat. I'll now be passing it over to Adam, the other co-founder of the organization, to introduce today's speaker.
Thanks, Nor. Hello, everyone. And as Nor mentioned, I'm a co-founder of the organization. It is so great to see all of you that joined today, and we're so happy that you're able to attend this meeting. We want to once again thank Dr. Webb for taking the time to present today. To quickly provide an introduction, Dr. Webb is an associate professor of biological sciences at the University of Notre Dame, and her postgraduate work includes postdoctoral fellowships at Indiana University School of Medicine and Johns Hopkins School of Medicine. Dr. Webb will primarily be speaking on cancer immunology today. Please remember to stay muted throughout the duration of the presentation to minimize distractions. Again, if any questions do arise, please type them in the chat and we'll get to answering them at the end of the presentation. With that being said, we will now hand the floor over to Dr. Webb for a presentation. Thank you.
Hi, thank you, Adam and Geraldine, for the kind introduction and for the invitation to speak about our work. So I'm so happy to talk to you about our work in cancer immunology and immunotherapy. And the cells that my lab focuses on are called natural killer T cells, or NKT cells. And the picture, the schematic in the middle, is showing you a white blood cell killing a tumor cell. And so that's what we want. We want to train your immune system to kill cancer the same way that it does for infectious diseases. So I have to disclose that I started a biotech a while ago and I work with other companies, and I will not talk about any of that work today. I would just like to say to dream big, because when I started out, I never imagined that I would work with companies. And so whatever you can dream or imagine, you can bring to reality. So stay focused and work hard. So first, I would like to acknowledge the people who did the work, because science is indeed a team effort. And so I will talk about some of our work on ovarian cancer that was done primarily by Irina and Dominique in the lab. And this is one of my favorite quotes from Pele, for those of you who are soccer fans. Success is no accident. It is hard work, perseverance, learning, studying, sacrifice, and most of all, love of what you are doing or learning to do. So stay focused, stay driven so that you can be successful. And I would like to highlight that I was able to start a summer program for underrepresented groups in cancer. And so it's an exciting time to conduct research and be a part of science and research. And I've had many different opportunities to work with throughout my career and with trainees. So this is a picture of my lab over the years, and a reminder that successful people never reach their dreams alone. So the focus of today's talk is on cancer immunotherapy. And that's because it's been heralded as the breakthrough of the year multiple times. And someone has actually called it the greatest thing since sliced bread. But if you look at this issue of time, it highlights several key questions. It says, what if your immune system could be taught to kill cancer? And again, that's our goal. We want to train your immune system to kill cancer because it could be more effective than any of the other treatments. Because classic treatments are surgery, right, to remove the tumor, radiation to get rid of residual tumor cells, chemotherapy, targeted therapy. And again, those are very effective. But now we know that your immune system can come in and get rid of cancer. And so then it goes on to say, inside they're brutally selective. And that's because cancer immunotherapy only works in 30 to 40% of the population. So that's great, right? It's amazing when it works. But if you're a part of that 60 or 70% for which it doesn't work, it's horrible, right? It's disappointing. Not only that, it can be hugely expensive. So it can cost $30,000 to $50,000 per cycle per treatment. So in the end, you could have a huge bill. But what we want to focus on are the life-saving trials of immunotherapy. So we can make therapies better so that they work for more people, they're less expensive, and can save lives, then we will achieve our goal. So again, that's what we want to do. And the cells that we work on are a specific type of immune cell called natural killer T cells. And that's because they have characteristics of both the early or innate and later adaptive immune system. So if you compare NKT cells or natural killer T cells to classic T cell subsets, you see that they do have a T cell receptor. But unlike classic T cell subsets that recognize antigens or things that are perceived by your immune system as being foreign, so again, these classic T cells recognize these peptide antigens as being something foreign that you can drive an immune response to, but NKT cells are activated by lipids, these glycolipid antigens. And the reason why we're focused on NKT cells is because while you have a diverse group of T cells, NKT cells are the same in everyone. So everyone listening here has NKT cells that recognize lipids presented by this protein CD1D, and it's broadly conserved. So again, all humans have the same NKT cell T cell receptor is semi-invariant B alpha 24, J alpha 18. So if we can develop therapies targeting NKT cells, again, it can be broadly applicable and be of use in many people. So NKT cells are really important for cancer immunotherapy because, as I just mentioned, everyone has them. And NKT cells can directly kill cancerous cells as well as activate other immune cells. And so NKT cells produce cytokines or proteins that help classic CD8 T cells or cytotoxic T lymphocytes, as well as natural killer cells, and they can induce the maturation of dendritic cells. So NKT cells not only can directly kill cancer cells, they can promote anti-tumor responses by activating and helping other immune cell subsets. However, it's known that NKT cells are reduced in many different cancer patients, and they're reduced in number and in function. And so that's why they've had limited success thus far. So again, our goal is to figure out why NKT cells are being suppressed by cancers so that we can develop therapies to target them. And so you may be wondering, how does this happen? So I've told you that we want to drive immune responses against cancer, but cancer still occurs. So why is this happening? And we call this the 3 E's of cancer immunoediting. So the 3 E's are elimination, equilibrium, and escape. So first you have the elimination phase. So what happens is here in gray are your cancer cells, this nasty gray color. And normally when you have cells that grow out of control, your body knows that these cells should not grow out of control. So they will either stop the cells and repair them, or the cells will die. If they don't do this, your immune system can come in and get rid of these cells. They can recognize antigens or things, again, that are perceived as being foreign and say, there's something wrong here. You need to be eliminated. So this is the elimination phase, and this happens all the time. It's estimated to happen 1 to 3 times per day, where you have a cell that starts to grow out of control, and if it isn't repaired, killed, or targeted by your immune system, it could become a problem. But this happens. Again, your immune system comes in, gets rid of it, and you never know. So right here in the talk, while I'm speaking to you, your immune system could be fighting off cancers, and you would never know there's a problem. However, cancer cells want to grow. So sometimes when they're not eliminated, it's because they reach this equilibrium phase. And what happens is they stop presenting things that the immune system can recognize, and they keep accumulating mutations. And so the immune system isn't able to get rid of it. And then they'll start to recruit in suppressive cells and secrete suppressive factors, inhibitory factors. And this allows them to escape. So they're able to escape immune detection, and that's when you have a problem. So why? Why is the cancer able to escape our immune system? What are reasons why the immune system may not be able to detect the cancer? So your immune system could be ignorant, and that means it doesn't know there's a problem. And cancers are horrible. They can actually make your immune immune cells die. And this is called deletion. So if they cause your immune cells to die or undergo apoptosis, then your immune system can't fight against the cancer. Or you can experience anergy. Anergy is different from ignorance. Anergy means that you're unresponsive. So let's say you're ringing a doorbell and you see the dog is just tired, and the dog would know that someone's there, but it just doesn't respond. So the state of unresponsiveness is called anergy, and that's what can happen. The cancer can make your immune system anergic or unresponsive or exhausted. And so then it would not be able to kill the cancerous cells. And then lastly, the cancer can actively suppress your immune system or block its effector functions. And we found this to be the case many times, where the cancer, again, will produce these suppressive or inhibitory factors and block your immune system. So we wanted to look at this further. And the cancer I'm going to talk to you about today is ovarian cancer. And that's because it's the most lethal gynecological malignancy affecting women in the US and worldwide. And that's because most patients are diagnosed at a late stage. And so while the majority of patients will initially respond to treatment, they eventually develop recurrent chemotherapy-resistant disease. And this leads to a poor overall survival rate. And what we do know is that patients will have this fluid that accumulates in their abdominal cavity, and it's called ascites. And so when I first started working on this, we wondered if in this fluid that accumulates in ovarian cancer patients, that this fluid had suppressive factors that could block the immune system. And so we wanted to look at this. So to test this, to see if ovarian cancers produced factors that could inhibit NKT cells, we collected fluid from a bunch of patients, treated our stimulator cells, the cells that would activate our NKT cells, and looked to see if after treatment they could still activate the NKT cells. And so I'm showing you this because, of course, we found that the ascites was producing these inhibitory factors. So on the bottom here, this is our stimulator cell that was just treated with media. So it's a negative control. What I'm showing you on the y-axis is inhibition of NKT cells. And so with media control, there's no inhibition. And then this is ascites from 3 different ovarian cancer patients. And when each bar represents a different NKT cell line. So when our stimulator cells were treated with ascites for 4 hours, washed, and then looked to see, we examined whether they could activate NKT cells, we found a 50 to 100% inhibition. So exposure of immune cells for just 4 hours to patient ascites block their activation. So we know cancers are producing these suppressive factors. So then we wondered, what is it? So we took a moderately inhibitory ascites and then extracted the lipids, because NKT cells are activated and suppressed by lipids. So we isolated the lipid fraction, treated our stimulator cells, and then looked to see if they could activate NKT cells. And again, you see, I'm showing you on the y-axis, activation is shown as percent inhibition. And most of the activity was in the lipid fraction. And so then with our collaborators, we were able to run TLC, or thin layer chromatography, to identify the lipid. And we found that it was a ganglioside. And the higher the level of gangliosides in the ascites, the greater the level of inhibition. So then we wondered, what is it, right? What ganglioside is mediating the suppressive? So we bought purified lipids and treated our stimulator cells. And we found that the activity was with this ganglioside GD3. And as a comparator, we compared GD2. And it's just missing 1 sugar. And what you can notice is we found a significant dose-dependent inhibition of NKT cells when we treated with GD3. However, with GD2, there was no effect. So if you look at each bar, black, stripe, or gray, there's no impact when we treat with GD2, but a significant reduction with GD3. So this was exciting. We've identified the lipid, the suppressive lipid in ovarian cancer patients that suppresses NKT cell activation. So then we wondered, does this occur in vivo, in a mouse? So we activated NKT cells in a mouse using this potent agonist, alpha-galactosylceramide or alpha-gal-cer, and we get nice activation of NKT cells in the mice. However, when we added in GD3, we found blockage of NKT cell activation. So this lipid is suppressive both in the dish or in vitro as well as in vivo. And for those of you who are wondering about the structure, here it is. So this was exciting. We found this inhibitory lipid. So this was great. This was work when I was first starting out. And then I had a graduate student who came into the lab and wondered if there were any other inhibitory factors. And this led us to look at vascular endothelial growth factor, or VEGF. VEGF is produced by cancers to help them generate a blood supply. So, you know, cancers want to grow and they need nutrients. And so they produce factors that allow them to develop a blood supply. And VEGF is important for that. And if you look in the literature, it's been shown that VEGF levels in ovarian cancer patient ascites is much higher than what's found in other solid cancers. Not only that, high VEGF levels are inversely correlated with survival. So if you have high VEGF, your chances of survival are lower. In addition, VEGF levels correlate with invasion and metastasis. And as shown in this picture, the schematic, VEGF also causes the recruitment of suppressive cells like regulatory T cells and myeloid-derived suppressor cells. So we decided to look at this further. So to look at this, we wondered first if VEGF is present in our ovarian cancer patient ascites. And indeed it is. And this stands for non-malignant ascites. It wasn't there. And this is our negative and positive controls. So VEGF is present. We looked to see if it was secreted by ovarian cancer cell lines. And indeed it is. 2 ovarian cancer cell lines, OVCAR3 and SKLV3, both secrete high levels of VEGF. And then we bought purified VEGF, treated our stimulator cells with it, and looked to see if they could activate NKT cells. And each bar is 2 different NKT cell lines. And we saw a dose-dependent inhibition of NKT cell activation when the cells were treated with VEGF. So VEGF is present and it is suppressive. So then we wondered, what if we block VEGF? Can we now restore NKT cell responses? So we used Avastin or bevacizumab. It's an antibody that binds to VEGF, as well as a tyrosine kinase inhibitor, Genenstein. This is a drug that's been shown to inhibit VEGF in ovarian cancer cells. So we use both Avastin and Genenstein to treat human ovarian cancer cell lines. And I'm showing you the data here. So we treated human ovarian cancer cell lines with Avastin and Genenstein, and then took the media, the spent media or conditioned media that the cells were in, treated our stimulator cells, and looked to see if they could activate NKT cells. And we found that when we blocked VEGF, either using Avastin or Genenstein, we were able to restore NKT cell responses. So this is great, right? I've shown you that GD3 is inhibitory, VEGF is inhibitory, but if you block VEGF, now you can regain or restore NKT cell responses. So then the student wondered, is there a link between VEGF and GD3? So the top is just showing you our controls, where we wanted to first measure and see if we could detect GD3 by flow cytometry. And the white histogram is our negative control. The gray is another negative control, and the red is GD3. So focus on the red, and you see we have nice staining. So we can detect GD3 in our human ovarian cancer cell lines. And importantly, when we treat with Genenstein that blocks VEGF, we see a shift, a leftward shift. So now compare the red to the blue, and you see that when we treat with Genenstein and reduce VEGF, we get a reduction in GD3. So this was great. It was the first time in ovarian cancer that a link had been shown between these two suppressive factors. So hopefully I've convinced you that we found that ovarian cancers produce these suppressive factors, namely GD3 and VEGF, that block the ability of NKT cells to become activated. And so to look at this further, I had a postdoc in the lab, Zodi, who developed 3D models so they could reduce the use of animal studies. And she looked at the suppressive cells, myeloid-derived suppressor cells, excuse me. In addition, I've had 2 high school students working in the lab. Zen worked on an ovarian cancer diagnostic and also worked with nanoparticles. And Elaine worked with breast cancer because we found that breast cancers also shed GD3. And she used some click chemistry in order to develop a way to modify antibodies so that we could develop a test for breast cancer. So it doesn't matter what stage you're in, you can always contribute to research. So again, stay focused and motivated, no matter what your stage is. As long as you're curious, you're interested, and you're willing to work, you can do research. So now I'll switch gears a bit and talk about cancer health disparities, because we've also done some work with breast cancer and ovarian cancer, examining health disparities in these areas. And so what I think you can appreciate is, so first of all, this data is from the American Association for Cancer Research, looking at the Cancer Disparities Progress Report. And what I think you can appreciate is that if you look at this arrow, you see over time, there has been a significant reduction overall in the number of cancer deaths. So we are making progress. Research is having an effect. But if you look here and compare different ethnicities, you see that some ethnicities are disproportionately affected. So I'm highlighting African Americans here because you see, if you look at the number of cancer deaths per 100,000 people of all ages, it's much higher in African Americans compared to other ethnicities. And so why is this? Cancer health disparities are due to a variety of factors. So it could be due to environmental factors, behavioral factors, social, clinical, and cultural factors, psychological factors can have an impact, as well as biological and genetic factors. So while the research in my lab is focused on biological and genetic factors, again, I just want to highlight that there are a wide variety or a plethora of factors that can have an impact. But if you look here at disparities in incidence and deaths between African Americans and whites for different cancer types, you can see across the board that for many cancers, the incidence is higher. So that means a patient who's newly diagnosed with cancer. If you compare the rates in African Americans, it's higher. And if you compare the death rates, it's higher. And so this tells you that a lot of work needs to be done, right? We've made progress, but there's so much more that needs to be done. And a lot of work focuses on different ethnicities and racial groups, but I just wanted to broaden your perspective and say that there's so many different groups that experience cancer health disparities. So if you look again, it does affect different racial and ethnic minority groups, as well as individuals of different ancestries, but also your socioeconomic status can have an impact. Individuals with disabilities, immigrants, LGBT members of the community can also be disproportionately impacted depending on where you live and if you have health insurance, if you're a refugee. Also, the very young and the very old are disproportionately affected. And so there's so many different groups that experience cancer health disparities. So again, there's a lot of work that needs to be done to understand why are so many groups disproportionately affected by cancer. And again, to look at this even further, because again, I really want you to think about this and take this home, and because you are the next generation. And so you're going to be able to come up with solutions to problems that we've experienced. And I'm so excited to hear about what you're able to come up with. But again, if we take a look at specific facts here, so this is US cancer health disparities at a glance. You can see that African-American men have a much higher risk of dying from prostate cancer in African-American women from breast cancer compared to their white counterparts. And if you look at Hispanic children and adolescents, they are 20% and 38% more likely to develop leukemia than non-Hispanic white children and adolescents. Asian Pacific Islander adults are twice as likely to die from stomach cancer compared to white adults. In addition, American Indian and Alaskan Native adults are twice as likely to develop liver and bowel duct cancer. So do you hear this? Twice as likely. That means that something has to be done. And again, I would be really interested in hearing about what you're able to come up with. So in collaboration with Dr. Jones, Dr. Lisa Jones at the University of Maryland, we've been doing some work on this to address cancer health disparities. And before we were looking at genomics, and then we decided to look broadly, think bigger, go into proteomics. And so she's developed this amazing technique called fast photochemical oxidation of proteins, or FPOP. And the cool thing about FPOP is that you can treat cells with the drug. So any drug, you can treat cells with the drug, label the proteins in the cells, and then see how the proteins change after drug treatment. And so that's what we did. So we've taken breast cancer cells and ovarian cancer cells from different ethnicities, from African Americans and European Americans, and look to see what happens. And so quickly, I'll show you that FPOP can be used to identify differences in proteoforms following drug treatment. So again, we took the cells, treated with a drug, and then looked to see what proteins were modified. And can you believe that the number of proteins that were changed were, you can see them here. There were so many proteins that were differentially impacted by drug treatment. So the same drug works differently based on your ethnicity. So that tells us that we need to do clinical trials that involve people from so many different ethnic groups just to really understand what best works for a particular individual. So for my final summary, I just want to quickly recap and say that there are many different factors that contribute to cancer health disparities. So what can we do? First, we need to increase diversity in the biomedical workforce. So in all areas of the biomedical workforce, researchers, nurses, physicians, clinical trial coordinators, therapists, in all areas, we need diversity. We need diversity of thought. We need cultural diversity. We need diversity in all of its wonderful aspects, to ask different questions, to develop new solutions to these issues. And then what can you personally do? You can decrease risk. So if you look at this schematic here, it shows many different cancer types. And the ones in this pinkish red color are those that are associated with obesity. So you can decrease risk by watching your weight, making sure that you exercise and stay healthy, because the ones in blue are associated with physical activity. So get out, take a walk, exercise, right? And reduce your risk for developing these different types of cancers. Also, we know that the earlier you get treated, the better your outcomes. So we need to increase early screening. So go to doctor's appointments, encourage your family members and your friends to go to doctor's appointments. Because again, the earlier that we detect the cancer, the better your outcomes. And then lastly, we can conduct more research. And so I'll close with this quote from Maya Angelou that says, I learned that people will forget what you said. People will forget what you did, but they will never forget how you made them feel. So you may feel that I've talked about a lot of science, and this may not be your particular area of interest or knowledge base, because I've been talking about immunology. But remember that I said, stay focused, stay encouraged, and bring your diversity in thought to the field so that we can develop solutions. So remember your purpose. And thanks so much for your time. I'd be happy to answer any questions that you may have.
Thank you so much for the amazing presentation. You really gave me, certainly, I'm sure everyone, a lot to think about. So thank you so much. So we will now begin the Q&A section. We're going to first start with the questions that were asked through the registration form, and then we will get to any questions that were asked in the Zoom chat. So this is your opportunity to ask questions, so please ask whatever you have in your mind. So the first question we received through the registration form was, do you have any tips for a 16-year-old or really any young person looking to go into the medical field or become a doctor?
Yes. So one of my favorite quotes is, ability is nothing without opportunity. So I'm sure that you are talented and you have the ability, but you just need the chance, right? So go out and explore different opportunities. I highlighted a couple of high school students that have worked in the lab. So you can work in a research lab, you can shadow physicians. I know it's been really challenging because of the pandemic to be able to get out and get those opportunities, but things are changing. We have a vaccine, we have multiple vaccines, right? So now use your time wisely and ask for opportunities. If there's something that interests you, go for it, because then you'll find what you like and what you really don't like and what you love, hopefully. So again, do not be shy, ask. You can ask your parents, friends, your friends' parents, or either your family members, your family physician. You can ask people that you know through sports, through church. Make contacts, because that will help you get the opportunities so that you can work in the clinic, work in a lab, work in a hospital, and see what's available.
Thank you so much for that very insightful answer. The next question we have is, what is something you wish you did differently while in the process of entering the medical field?
Oh, so another one of the quotes is, just because you can doesn't mean you should. So when I was in undergrad, I was pre-med and I thought that I wanted to go to medical school. I conducted research later and loved it. I was like, oh, I can fight that. But before that, I worked in college. I worked a regular job. I worked at Toys R Us, which you don't have now, but I worked at Toys R Us, as well as I was an elementary school teacher for ESL, English as a second language. And I worked in a hospital as a child life volunteer and as an interpreter. And I did all of that while in college, which sounds like a lot because it is. And so I wish that I would have just taken the time and really focused on my studies and did just a few things. Because again, just because you can do a lot of things doesn't mean you should. You could do just 2 of those things really well, or do a lot of things okay. And you want to do as great of a job as you can. So again, take advantage of opportunities, but make sure that you stay focused so that you can have the best experience and do the best that you can at what you commit to do. Because if you say you're going to do something, do it, but make sure that you can do it to the best of your ability. So again, I wouldn't have overcommitted myself because it made it much more stressful. And I didn't have time to do some of the things that I probably should have done. So again, stay focused and stay driven and do what you can, but do not overcommit, and make sure when you say that you're going to do something, you follow through and do it.
Thank you so much. That was more applicable than just the medical field. That was really great. Thank you so much. So the next question we received is, what can we do in our daily life to live healthier lives and hopefully avoid cancer?
Oh, so that's a great question. And I kind of tried to touch on it in the last slide when I said to exercise. So there are little things that you can do. Just exercise, watching your diet, taking care of your health, making sure that you have your regular physical appointments, at, the physician's office, having regular dental checkups, taking care of your hygiene. Again, just taking care of yourself, taking time if you want to meditate or yoga, whatever works for you so that you can de-stress. If you just like to sleep to de-stress, make sure that you take time for yourself. So you're going to go out there and do these amazing things, which I'm so happy about, and I'm looking forward to seeing what you can do. But make sure that you take care of yourself while you're taking care of all of the other things and everyone else.
Thank you so much for that detailed response. And the next question is, how do people get different types of cancer?
So that's an interesting question, and it can be very broad because I think that people often think that we have been working in the field of cancer for so many years. And so why isn't there one particular cure? That's because there are so many different types of cancers, and there's so many different causative agents. So cancer doesn't happen just because of one thing. You have to have multiple hits, right? So you have multiple mutations in a cell, and the cell has driver mutations, things that allow it to continue to grow when it should die. And so we need to figure out how to attack those major mutations that are essential for the cancer to live. And for different cancer types, those are different factors. So there are so many different factors that drive each particular cancer that there isn't one good answer that fits everything. Again, you can have, when I showed the cancer health disparities slide and said there's many different contributors, that's the same thing for cancer. So you could have genetic factors. So you could have injury, genetic mutations, you could have infectious agents, you could have so many things that happen that drive that cell to become cancerous, to start growing out of control. Then that cell will develop mutations so that it continues to grow, and the regular normal senses of checks and balances that would make the cell die, the cell is able to overcome that. And so again, for every different type of cancer, there is a different situation. And then once the cancer starts to grow, if you take a mass, so like let's say I have a mass here on my neck. If we did surgery and removed that cancer and looked at that cancer, all of the cells in that cancer is not the same. They are not all the same. So can you imagine that? There's heterogeneity amongst different cancers, as well as within that same cancer. And so that's why there's so many different cancers.
Thank you so much for that detailed response. Just for all of you that are writing questions in the Zoom chat, we will get to them at the end of these questions. These are the questions that were asked in the registration form, and then we're going to hop right over to the questions that were asked in the Zoom chat. So the next question that was asked through the registration form, it was, in your opinion, are we far away from a cure for cancer?
So, this is the field I work on. So of course I'm going to say no, we're not far away. There are some curative therapies, right? It depends on the cancer type. And in the beginning, when I talked to you about immunotherapy, it works in 30 to 40% of patients. So we can have patients that have had 2 to 11 other types of treatment. and those treatments did not work. But when they received cancer immunotherapy, their cancer goes away and they are cancer-free for 10 plus years. When the cancer goes away and is not detected for 10 plus years, we can consider that a cure. So there are curative strategies for some cancers. That happens now. It's just, again, there's so many different kinds of cancers. And if you're diagnosed late, it's harder to treat. And so that's the problem. And so, again, every day there are millions of people working towards cures all over the world. So yes, I do think that we are closer to a solution. Every day we could be finding a solution, but it probably is for one particular cancer type. And because there's so many different types of cancers, and cancers are diagnosed at so many different stages, you have to have the treatment that works for that patient at that stage. And that's the problem. That's the critical issue.
Those were some great points that you brought up, and also you explained the nuanced viewpoint of cancer treatment. So thank you so much for bringing that up. The next question we have is, what inspired you to become a scientist of cancer immunology?
Oh, so that's a great question. So actually, my doctoral work was in infectious diseases, and I worked on viral immunology. And that's great, right? Because right now we're in the middle of a pandemic caused by a virus. But then I transitioned into working in transplant, and that showed me how what we're doing in the lab could be applied into the clinic. And so I wanted to do more work that was clinically focused. And my grandfather battled prostate cancer for more than 10 years. And so then I thought, if I could contribute to the cancer field, then that would be a great way to make an impact. So where you start doesn't have to be where you finish. Again, I started working with viruses and in viral immunology. And actually my first summer research program was working on a vaccine for HIV. So again, you can explore different areas and see what fits. But what really made me want to work in cancer was the fact that we were developing all of these strategies that could boost your immune response against cancer and help your body fight off its own cancer. And so again, I thought that if I could contribute, then that would be something great.
Thank you so much for that great response. So the last question that I received here through the registration form was, what advice would you give to someone interested in cancer research?
Do it. No, I'm saying. So if you want to do cancer research, you have the opportunity. I recently started a summer program called the Diversity in Cancer Research Program. It's sponsored by the American Cancer Society. And so I'm able to give opportunities to undergraduate students, but there are programs like this all over the world, all over the United States. And again, I've had high school students, undergraduate students, college students, graduate students, postdocs. I've had people who are professors at institutions in different countries come to the lab. So wherever you are, take advantage of the opportunities. So just go out there and explore, because you may find an area of cancer research that you really love, and then others that are intriguing, but maybe not a great fit. So the earlier that you start, the more you can figure out what you love, and you can develop those skills and those techniques to answer different questions. So I would strongly encourage you to go for it.
Thank you for that very inspiring answer. And now to just transition into the Zoom questions. One of the first questions we had was, I think it was about one of the earlier graphs you showed in your presentation, and asked, how did you know that the lipid values measured were only representing the inhibitors and not other lipids in the body?
You asked about the lipids that we measured and how did we know that it was specific for that particular lipid. So that's a great question. You always have to have controls. So when we isolated the lipid fraction, we isolated the polar lipid fraction, and this was done in collaboration with Dr. Ron Schnarr at Johns Hopkins. He's a glycolipid biochemist. So when you don't know something, go to the experts and have the experts help you. So again, I didn't know about lipid biochemistry. So I went to his lab and he was able to give me a protocol and help me. I worked with someone in his lab who's now a professor in Argentina. And we were able to isolate the polar lipid fraction from the patient samples. And then that fraction has both polar lipids that are phospholipids as well as gangliosides. And so then we further separated out that fraction, the ganglioside fraction, and ran it on that TLC. And we also performed mass spec to see what we were looking at. So again, you have to do multiple techniques. One way is not sufficient, right, to really figure out what you're doing. So you should try it multiple ways. And not only that, once we figured out what we were looking at, that lipid GD3, we purchased an antibody specific for GD3 and treated the patient ascites with it, and then looked to see if once we got rid of GD3, what would happen. And we lost a lot of the suppressive activity when we got rid of GD3. So make sure that you do it multiple ways, you confirm it, and you get an assay that's as sensitive as possible. And so that's what we did to make sure that we were looking at the right thing.
Thank you so much for that response. And the last question we received here through the Zoom chat, if we don't get any more, is how can medical students turn into good researchers?
And time and practice, right? Like everything else. So in medical school, you are taught to learn so many different things because you're going to meet people with so many different situations, and you need to be able to quickly respond knowledgeably, with compassion, and treat the patient, right? They're giving you their trust, and you have to treat them. And of course, do no harm, but to the best of your ability. So you're thinking that way. And in research, we are thinking about questions. There's so many different questions out there. So we are thinking, what are good questions? How do we solve them? Do we have the technology? Do we have the resources and facilities to really address this question? So you have to broaden the scope, I think, of what you're thinking, and then just time and practice and patience. And again, medical students are extremely smart, right? Highly knowledgeable, very compassionate people, that you have to have that compassion and empathy to provide good care. And so when you turn that into your love for research, then you can do so many amazing things, and you'll see things in a different way than someone who's been doing basic research their entire lives. So it would be great for medical students to contribute to the biomedical research field and bring all of that knowledge and all of that compassion and answer questions again in a different way. So again, I think that's just adding more diversity to the workforce. So that would be great.
Yeah, that was a great answer. And the last and final question that we have from the Zoom chat is, what factors are most responsible for the recurrence of cancer?
Oh, so that's a really great question. So I'm not sure if you've heard about cancer stem cells or stem-like cells, but those are those seeding cells, the cells that are able to grow into the tumor. And so you can have those cells once you get rid of the main tumor, the bulk tumor. So again, if we had a mass here on my neck and we performed surgery, got rid of the major mass, and then performed treatments, radiation, chemotherapy, targeted therapy, immunotherapy to try to get rid of the remaining tumor, but there are few cancer stem-like cells remaining, then those could come back in the next few years and regrow the tumor. And so that's what we need to get rid of. We have to get rid of those stem-like cells in order to be able to make the tumor stay away and not reoccur. So did I answer your question? Can you please re-ask it? I want to make sure that I really address the question.
She
Yes.
just wrote in the chat she said yes.
Oh, okay.
All right, yeah, so thank you so much for all those great answers. We'd once again like to thank Dr. Webb for taking her time today to give us an introduction to her work. And thank you all for attending today's presentation. Please use the link posted in chat to obtain your shadowing certificate. And thank you all so much for attending, and we look forward to seeing you at our next meeting. We're going to stick around for a couple more minutes to make sure that everyone has access to the link.
Thank you so much.